So, good afternoon. Thank you for coming back from lunch. Hope we'll keep you awake after you've all had that nice food. I have no disclosures. I forgot to add that on my slide. So there we go. And I apologise to some of you because some of this slides and some of this presentation is resurrected from one I did a few years ago. So some of it is new and different. So our aim this afternoon is to identify the elephant, that of sex and intimacy. We're going to discuss some possible solutions, and these are just from my experience, for this difficult area of care. And then hopefully give you some skills to enable you to discuss these issues just a little more confidently. But first, some background to our service and how this topic came about. So I work with Renee, who spoke this morning, and we are a multidisciplinary community chronic disease team that provides a service to clients with MND. We have a current caseload of 48 active clients. We provide an ongoing service for these clients from referral to the Princess Alexandra Hospital right through to end of life. Since its inception, we've supported 143 clients through our service and their families, which has built our skills and knowledge, resulting in a highly experienced team that's both proactive and responsive to the changing needs of these clients. We've very close links with the hospital, which enables us to liaise with the medical staff, preventing those admissions. As a community team, we also triage the hospital clinic, so clients only attend if they have need. If they're fine and they're stable, let's keep them at home. Let's not just take them up to the hospital just to say, hi, I'm fine. So because all care is provided at home, in patients' comfortable space, we're able to build those relationships with them and their families. That facilitates these difficult conversations. They also start to feel more comfortable talking about all their concerns. So here's the elephant. It's a bit awkward. Yes, I have MND, but I don't have to worry about falling pregnant, surely. My hubby's struggling with changing pads, never mind sanitary products. My wife is 3 months pregnant. I can't masturbate. Is it due to MND? And not because my hands are weaker, although that's making it hard. And the worst thing about MND is having an erection I can't do anything about. So these were statements presented to me from clients and family members. Mostly caught me by surprise. Some I found a bit confronting. Some required very good straight-faced acting skills. Try not to say, what? Having looked after a significant number of clients with MND, began to realise that this topic isn't an area that we discuss, but one that we probably should, as it's those underlying concerns that clients have that get blurted out when they've summoned up the courage to raise it. And that can be to whichever clinician happens to be there at the time, or they have the best relationship with. It doesn't just have to be us nurses. Hence, Renee got some comments this morning, and our physio has had some comments meant to her. It's like, this is not my area of expertise. So we have to bear that one in mind. But according to a study by Dyer, come back one. What happened to that slide? Sorry. According to a study by Dyer in 2013 as to why health professionals don't talk about sex, these were some of the reasons that were identified. Concern about our own knowledge and abilities. It may be you've never had to discuss it, so it creates an anxiety within you. Personal discomfort. Some people just don't want to go there for a multitude of reasons. Possibly your own beliefs, your upbringing, you've had some bad sexual experiences. A lack of awareness about sexual issues. None of us like talking about what we don't know about. Fear about opening up a can of worms. Where might this conversation be leading? A lack of time, resources, training. If we aren't experienced and have never had any training in that area, it may be we have our own agenda for the consult and we don't want to get sidetracked into something we're not really confident about. However, we need to overcome these obstacles, as the evidence shows that both patients and health professionals are aware that we don't talk about it, but the patients often want to. So for a moment, let's just digress and look at some of those issues raised at the beginning. Pregnancy and MND. So what if someone did get pregnant? I wonder how the physical demands of pregnancy would place on the body would affect the MND progression. I could only ever find one case study from 1984 with a pregnant lady with MND, and in that study it didn't appear to increase the disease progression. However, there would be significant concerns. We'd need to have close monitoring of the respiratory function. Riluzol's never been trialled in pregnancy. There'd be issues maintaining the body's energy demands. Pregnancy does that on its own, but add MND to that as well. I'm sure it'd be a challenge for many dietitians. What if they have bulbar symptoms and need a gastrostomy tube? What if they've already got one? And then, of course, they'd need a section and the increased risks of that. I can remember a husband's face when I told him his wife could still get pregnant. She'd sadly just been diagnosed post-delivery of their first baby, who was about 6 months old when we first met them. And it was a really random comment he made. We were just having a conversation, and he said, well, she can't get pregnant now she's got MND, can she? Of course, my immediate response was, yes, she can. So that followed on to a discussion that we had about contraception, and then realising that if we can stop menstruation as well, that also helps the partner. As I'm sure most chaps don't relish the idea of changing sanitary products. If we refer back to the care guidelines, they all talk about promoting intimacy, and we've talked about that a bit this morning. And we need to promote it as long as possible and maintaining that active sex life. So the possibility of an unplanned pregnancy is possible, so it is an area worth addressing. So if we want to stop pregnancy and have the added benefit of stopping or reducing menstruation, then using a long-acting contraception is going to be the most reliable method. It needs to be in discussion with both the client and the GP, as all long-acting reversible contraception increases the risk of DVT and hypertension, and our clients with reduced mobility are already at risk, so they need to be aware of the increased risk. However, all three methods have their potential difficulties. We've got the injections. So these are high-dose estrogen, given every 3 months, and they'll be the most reliable in stopping menstruation. But there are issues about who will give it if they can't get to their surgery, as that's the most common place for administration. It will depend on what community services they have available. Then we've got your hormonal intrauterine device. That lasts for 5 years. If they've already got one, you need to know when it's due for changing, so it can be done while their mobility is still okay and they can get on and off a bed. If they don't have one, it is a good option as it lasts for the longest duration. The subdermal implants last 3 years, easier to change if needed in terms of not having to get on and off beds, but they don't give such reliable period control, and there's still the issue of their function in getting out when that 3 years is up and to have it changed. I had a lady last week who just missed her first period since having her injection and was just so excited and wondered why on earth she hadn't used this for the last 20 years. So at least are happy ladies too. However, our ultimate aim is to relieve the partner of that part of care and make it a little easier if possible. So there's something for all of you to think about. Then we had the client who stated that his wife was 3 months pregnant. They'd already got a 3-year-old and his MND was fairly advanced. So after I sat and thought about it and didn't ask about how that happened, but anyway, it did have a different set of challenges in regard to the practical care requirements, especially he was rather a big chap. So one of our main challenges was in performing his transfers. They were unable to use, they were insistent on using a standing hoist, which the occupational therapist has deemed unsafe due to his current physical state, but his wife found that one much easier than using a floor hoist. We had many a discussion about regarding not only his safety if he fell, but both hers and the baby. Her fatigue as her pregnancy progressed, although an issue, was overcome fortunately due to the family support that they had. They also had a great NDIS support coordinator who over time actually managed to get them 22 hours care a day, which was amazing, and actually sorted out the care and transfer issues as well. There was a lot of emotional challenges with this family. They very, very much shut down on discussing the future. Palliative care was involved, but very minimal end-of-life discussions were ever had or allowed. They were very much focused on trying to solve his pain, which was significant. And interestingly, everybody involved decided that his pain was psychological, which again was talked about this morning. They just couldn't get good control of his pain despite lots of analgesia, good pressure relief, lots of discomfort measures. But juggling the care her husband required while she was pregnant, the demands of a new baby and end-of-life care at the same time must have been really stressful for them. They all offered psychology, all of that was offered, but they declined it. They did have good friend support, they had good family support, so that seemed to get them through. But in caring for this family, it did raise lots of issues for us and discussions during their journey from which we've learnt from, although recognising that all families are different and another's journey may look and be managed very differently. Sexual needs. MND doesn't affect sexual function or needs. Both involuntary and to a lesser extent the voluntary muscles are involved in sexual arousal and satisfaction. But what that means essentially is that most patients will find their sexual sensation and pleasure to be intact, which applies to both male and females. So when discussing this gentleman's inability to get an erection to masturbate, I had to explain to him it wasn't due to his MND. He eventually got that, and the conversation went down the lines of erectile dysfunction. Causes of that, was it any of his medication? In his case, it was likely due to the fact he had peripheral vascular disease as well, and he was advised to go back to the GP and discuss it, which he did. The other chap, though, although said to me in a very, very jokey manner, catching me off guard, was very serious. His morning erections were a big issue. His MND, he'd had it for 9 years. He had no partner. At the time, was living with his mum. Wasn't great when she walked in every morning. Fortunately, they're a very open family, but it has been a problem for him for some time. However, it was one problem that I actually didn't have a solution for. His brother had been taking him to a local brothel until lifting him in and out of cars and on and off a bed became too hard. And he's currently looking to see if he can find carers from overseas that will service all his needs. But he wants NDIS to fund it as well. Currently, NDIS don't fund sexual services. However, in July, precedent was set in Australia. There's a severely disabled lady with MS that has had sex therapy funded via NDIS to help her adapt her sexual activity and needs to her disability. So watch this space, guys. So, I've only touched on some examples, and obviously there are many, many others. But what these scenarios raise is that things change, and there are issues that we have to face and that concern our clients. We have the physical changes. They have decreased respiratory function, muscle power, stiffness, saliva. All things affect not only their ability, but their body image. We have the practical changes, equipment such as electric beds, air mattresses, ventilation masks, communication aids, gastrostomy tubes, all restrict that sexual intimacy. And then, of course, we have the relational changes, the couple dynamics that change. There's often a change in romantic relationships. There's a change in role from wife, husband to nurse carer, and that change results in less time or desire for intimacy. When someone's living a life-limiting illness, their coupled relationship is also dying. Taylor did a phenomenological study looking at sexuality and intimacy in terminal illness, which found that as their disease progressed, patients and partners experienced a variable connecting and disconnecting within their relationship, becoming apart as a couple, but it was experienced as a loss of spontaneity, a lack of reciprocity and rejection. And that then leads to those further emotional changes. We have poor self-image, fatigue, and of course we have the anxiety and the depression. We also can't forget the impact on the patient's partner as an additional factor. So most partners experience their own depression, fear, grief. If the partner's the main caregiver, which is often the case, there'll be overwhelming feelings of exhaustion, resentment over care duties, all which can interfere with those sexual feelings. These issues aren't insurmountable. Communication, which is non-verbal, especially touch, between partners is really important and probably the most significant access to that sexual intimacy. Encouraging partners to acknowledge it and process it together can help restore that intimacy as well. But overall, that loss of sexual and physical contact is often a really common cause of sadness for couples. So we've looked at some of the specific issues. We've looked at why we don't discuss them. So let's have a look at some of the possible ways we can introduce this subject. Firstly, we could introduce the question during our initial assessment. We have a really long, big assessment form when we ask all this stuff about clients, and we could add this in there in a really gentle manner. So we could suggest, you may not want to answer this, but people with illnesses often experience sexual problems and or a change in their sexual relationship due to the illness. Is that an issue for you? Depending on their response, you could offer, would you like to talk about it? Or you're welcome to talk about it another time if you change your mind. You're then leaving the door open to let them know that you're happy to talk about it and that they can raise it again. For clients to answer that question before you've built any rapport, to be fair to them, is really hard. But once you've got that relationship with them, they're much more likely to raise it. And it lets them know that you're okay to discuss it. If we're not happy doing that, the other thing we could do is leave the information for them. We've got a resource book that we give to clients when we very first see them. It includes lots of information, lots of fact sheets. We flick through it with them, highlight the things that are important at the time, but it's there for them to look at and refer back to when they feel ready to look and face some of those issues. So by leaving these leaflets in there, MND UK, do it great, and we have those in there, and the information's there for them to read when they're comfortable, when they want to, and then they don't have to discuss it with us if they don't want to, but we can re-refer to it and ask the same questions again as time progresses and come back to it. Another suggestion we could do is we come back to the subject at trigger times. Hospital beds, which I should have put electric beds, especially after this morning, when couples have to separate from their double bed. Mattress changes. Air mattresses aren't designed to hold two people, bit like being in a waterbed, wouldn't it? Up and down. When patients are unable to roll in bed, which way will they face for comfort versus connection with their partner? These changes may mean they have to sleep in separate rooms. Again, we mentioned that this morning, due to lack of space, possibly. But even if they don't, it's keeping those beds being separate if they have to be, depending on what resources they've got in their house. It contributes to that uncoupling, that feeling of loss. And it's about trying to find those solutions to maintain that intimacy. It's about us recognising it's still really important and not thinking that the best solution that we think is the best solution for them. But finally, if it gets brought up and you don't really feel able to talk about it, just explain, refer it on. I'm really sorry, I don't know the answer to that one. I don't feel comfortable talking about that, but I'll find somebody that will, okay? But at the end of the day, just have a go. Just address it so people aren't left wondering. And the more you have those conversations, I promise you, the easier it gets. But often it isn't that the clients actually expect you to solve everything and have all the answers. They just need the space and the ability to actually voice their thoughts and have somebody that will listen to them. There's some references for you, and there's my contact details.
Thank you. I believe we'll have some questions way in the back over there. I did like that, just address it.
Have a go.
It's kind of the key thing.
So, thanks for that presentation. I'm Steve Bell. I'm from the M&D Association in England, Wales, Northern Ireland. Thank you for referencing our materials. That's really good. Just to say that is currently actually being revised as well.
Fantastic.
As an association, we give quality of life grants to individuals with M&D, and only very recently we had a request for someone who lives in a residential care home, who the care home won't allow a sex worker to come in, and requested of us a grant so they could go out in a taxi and go and pay and go and visit a sex worker. What an ethical challenge, you know, for a charity. Yeah. We haven't resolved it, we're still talking about it, but you know, thank you for raising it, because that really is an elephant in the room, particularly when you're someone with this disease that lives alone.
Mm-hmm. It's a question in the front.
Roughly, what percentage of people do you think have this problem? Because I feel very guilty. No one's ever raised it with me, and I wonder whether I've missed lots of people with that. So roughly, what percentage, and is there an age spread?
I mean, it doesn't come out an awful lot, and I think that's a really difficult one to answer because you only know about the people that are going to talk to you about it. And I think in doing this presentation, it made me think about it even more, that we actually aren't as good as we should be. And I mean, even though we've got those resources and we've only added some of those relatively recently, we're still not good at bringing it up. You know, and I think it also varies on your confidence levels and what you've had before. You know, I used to work in sexual health and family planning in the UK many years ago, so it doesn't faze me. But I've got colleagues who go, no, I'm not going there, you know. So I think it works both ways. And I think if your patients are comfortable with you, they're more likely to. But as for a percentage, I mean, it's something that everybody has an opinion about and a feeling about, and will be of varying degrees of importance to them, depending what relationship they're in, whether they're single, they're in couples, or whatever relationship they're in, it's going to have some relevance. But as to a percentage, I wouldn't like to put a guess on it.
And a sub-question.
Go on.
Any difference with M&D FTD?
I haven't come across it with the FTD. Not saying it's not there, but I haven't come across it as yet. I'm sure there will be a time.
I do some FTD work separate from M&D, and it's definitely a quagmire. Yeah. The FTD and sexuality in general.
I think we've not, I say not currently, we've probably got a couple with FTD as well at the moment, but not many, but we've had a few in the past, and it probably is something that we should have talked about in hindsight. But you learn as you go through, as you do these things.
All right. Okay. Thank you very much.